In this video, we are going to cover just the basic steps of coding. So the first thing that you need to do is review the health records. So you get a record and you need to code it. That's the very first thing you need to do. The goal of that review is to identify all of the diagnoses and procedures that need to be coded and to identify the principal diagnosis. Now, the review of the record is going to depend on what type of record you are reviewing, whether it's an inpatient record, an outpatient record, an ambulatory surgery record, a physician's office record, long-term care. It's just going to depend on what you are reviewing, okay? In order for you to identify the actual principal diagnosis and the principal procedure, you are going to have to do a thorough review of the record. You can't just look in one spot and be done. All right? So let's move on. So, key pieces of the record that you are going to review. You are going to review the discharge summary. Okay? That is the first step, if it is available. It's not always available, but if it is available, you're going to look at this. What does the discharge summary do? Well, the main point is that it gives a synopsis for the entire encounter for the patient, from the time that they come in until the time that they leave. It's just a synopsis, all right? Consider it the book review of the book report of the health record, okay? So, most of the pertinent information in a record will be contained in the discharge summary. And in the discharge summary, the physician will list diagnoses and procedures that they evaluated, treated, monitored, or that they conducted during the encounter. Don't think that everything is going to be in that discharge summary, though, because it won't be. There will be things that they miss. There will also be things that they add. That there's either, if there's something that they miss, there will be information in the record in other places to support a diagnosis. For instance, a physician does not say that a patient has pneumonia in the diagnoses in the discharge summary. However, as you're going through the rest of the chart, you see that the patient was given breathing treatments, that there were infiltrates noted on the chest x-ray, that they gave the patient antibiotics, etc. And you know that it looks like there's information to support pneumonia. The flip side of that is it could say that there's pneumonia in the discharge summary diagnosis list, but then when you get into the record, there is absolutely nothing to support it. No chest x-ray, no breathing treatments, nothing. Okay? So don't just rely on that. It's not like a one-stop shopping thing. Okay? For long stays, many times a discharge summary will only focus on what took place in the last part of the stay. So if you have a stay that's 2 months long, it's very possible that that discharge summary will only cover the last 2 weeks, the last 3 weeks. So you'll really need to dig into the record then, okay? When you are dealing with a discharge summary, it's a good place to look because a physician will deal with and will mention diagnoses that are not currently being treated in the facility or that are not of importance. For instance, hypertension would be one. A lot of people have hypertension. So, in that case, you're going to see the physician will write history of hypertension in the medical history or history in the personal history. When that's the case, then that's your cue to go back and look. Did they do regular blood pressure monitorings? Did they give any type of antihypertensive when the patient was in the hospital as a medication? If they did, you're still going to include that diagnosis as reportable. All right, so it's a really good place for you to get a lot of information on a patient's chart, record, okay? All right, other places that you can look for a principal diagnosis. What if you can't quite figure it out there? What if there isn't one there? What if there is no discharge summary? Go to the emergency room record. That should be your next step, okay? that emergency room record will always, always, always have a chief complaint. And what is the chief complaint? The chief complaint is what the patient, the reason the patient's there in their own words. Okay, so for example, I have a bad cough, a fever, and a headache, and my throat is so sore I can't even swallow liquids. That is the chief complaint. All right? The next thing is the physician, the ER physician, will list a diagnosis for admission to the hospital. Most of the time, when an ER physician lists these, many times it will say possible pneumonia, possible something, suspected pneumonia, known whatever, differential diagnosis of, because they're not giving an absolute definitive diagnosis because they're not really sure. You know, it's a quick and dirty look at what's going on with somebody, getting them stable and getting them upstairs so that the attending physician can then take over and do what needs to be done. All right, so for example, with the chief complaint that I just gave, the example I gave for that, this is what the ER physician might write. Admit patient to the hospital for possible pneumonia and dehydration. So the pneumonia had not been determined, right? But the dehydration is probably known. Okay, so possible pneumonia and dehydration. That doesn't mean possible pneumonia and possible dehydration. That means possible pneumonia and the patient has dehydration, because they can tell that in the ER, right? A differential diagnosis is when somebody presents to the hospital or to the ER with a symptom that could be a variety of different things. So, for example, a patient with abdominal pain presents and the physician suspects that it could be appendicitis, gastroenteritis, cholecystitis, could be any of those. Those are the differential diagnoses: appendicitis, gastroenteritis, cholecystitis. Okay? So there are different types of diagnoses, but that's a good place to look, is in that ER record. Okay? Next thing you do, you keep looking. There are additional places you can look for diagnosis and procedures: progress notes, operative reports, anesthesiology notes, consultations. You know, there's those progress notes. The physician goes in, someone has to document on a patient every single day. Just a plethora of information in progress notes. Operative reports, lots of information there. Anesthesiology notes are ones that are really overlooked. They have excellent notes. Those anesthesiologists know what's going on with the patient because they don't want them to tank when they're giving them anesthesia. So they need to know everything, right? Consultations, another excellent place to look. Identify all of those procedures and those diagnoses. Write them all down. Just write them down. Get a piece of paper and start writing. Doesn't have to be good, just make yourself some notes. Pneumonia, cough, fever. Write everything down that you think, and then once you get those things done, you can start looking at what was a symptom of what. Do I have a more definitive diagnosis? And you can cross some of those things off. Okay? All right, so first thing you're going to do is you are going to determine what your main term is. You are going to locate that main term in your alphabetic index, right? So go locate pneumonia in the alphabetic index. Okay? If you look, and this is kind of tiny, but if you look, pneumonia, all of these are non-essential modifiers, and here's our default code. Okay? All right. Now, the main term is usually identified by a disease condition or a noun. It's not a body part. It's not a site. So it's a disease. It's the name of a disease. It is a disease that's named after someone, Alzheimer's. It'll be a noun. It will not be arm, leg, lung. It will not be that. Okay? Your subterms are going to give you further specificity. So, let's say you were looking for a patient that had Klebsiella pneumonia. Where would you look? Well, the first place you would look in the alphabetic would be pneumonia. Then under pneumonia, you would look for Klebsiella. Okay, so here we go. Pneumonia, that's our main term. We know it's our main term because it is bold and it is flush with the left margin, right? Then we want Klebsiella. And what do we have here if we keep going down? Klebsiella pneumoniae, 482.02. So, Klebsiella is the subterm of pneumonia, right? Okay. So, if we look at these, gastric upset, chronic mastoiditis, and herpes simplex, what's our main term for each of those? Well, gastric upset would be our main term. Mastoiditis would be our main term. And herpes would be our main term. Those three, upset, mastoiditis, and herpes, are the main terms for those three conditions. Okay? Now, main terms, when you get into the alphabetic index, you have more than one place that you could look. We talked about this just a minute ago. Eponyms. What is an eponym? It is a disease or a syndrome that is named for a person. For instance, again, Alzheimer's disease, Parkinson's disease. Those are eponyms. All right? You could look under eponyms. You could look under the name. Okay? Adjectives and anatomic sites are not usually main terms. So again, body sites, body parts, those are not going to be your main terms. Okay? If you were to look up chronic otitis media and you went to chronic, it's going to tell you to see condition. Well, what would our condition be there? Otitis, right? Let's say a diagnosis of an ischial fracture. The index for ischial fracture would direct you to go to the condition. Or what would the condition be in that place? What would the main term be? Fracture. Okay? Do not forget to follow your don't forget to follow your conventions. C also. Okay? Z codes, that is an ICD-10 thing. You don't need that yet. You do have some exceptions to the rule, which would be pregnancy in the purpurium and sequelae. All right. Obstetric conditions or pregnancy would be found under the main terms pregnancy or purpural. All right. Because pregnancy changes the whole thing. It's a whole different ball of wax. Sequelae, there will be a main term for that as well. So we'll be talking about that in a little bit. What's the most important thing here? You never, ever, ever code directly from the index. Okay? So, what do we do here? Here we've got C also. Here we have C. What does C also mean? C also means what? Hey, there might be someplace else for you to go. There may be a better term. Why don't you take a peek if you want? C condition right here is you don't have a choice. Go look, right? It's mandatory. Okay? So the procedure alphabetic index is a little bit different and it can be confusing. Okay? Finding a term may be difficult when you're talking about that. For instance, many times physicians will call a procedure by the name of the equipment. For instance, Swan-Ganz. You may see inserted Swan-Ganz. What is a Swan-Ganz? A Swan-Ganz is a type of catheter that goes directly into it's a pulmonary artery wedge pressure monitor. So it goes directly in, it's an arterial line, okay? But they don't say an arterial line for pressure monitoring. What they say is Swan-Ganz. So you need to know. You may find this under Swan-Ganz. You may find it under catheter. All right? You never know where you're going to find it, so you've got to really look. You have to really, really look for that. If you look under Swan-Ganz, take a peek. You won't find it. Okay? You've got to really understand what you are using and what that patient is, what that physician is doing. Okay? If you don't know it, what do? You look it up. If you don't know it, you have to look it up. You have no business coding it whatsoever. Okay? Because, as I said, something could be listed under one thing, it could be listed under another. In the instance of Swan-Ganz, it's not listed under Swan-Ganz. If you don't know what that is, you're not going to be able to code it. Okay? And again, don't code directly from that index. Okay? This is about PCS, ICD-10. We're not going to get to that yet. Okay? All right, tabular list. You're going to go verify your code in the tabular list. Why? Because you're going to look for exclusion notes, you're going to look for inclusion notes, any instructional notes that are there. That's going to be your next step. It doesn't hurt to look around that code. So maybe you're looking in a category code and you've gone to one particular subcategory. It doesn't necessarily hurt to look at the rest of the subcategories in that category. However, don't get distracted. Many times a rookie coder will get distracted because they think, oh, well, that might work better. So just be wary of that. Browse it, but be wary, okay? Also use Coding Clinic for clarification. Now, we're going to get into more Coding Clinic, like I said, when we get to using the encoder, all right? But we're not there yet. We'll be there, I believe it's week 9 or 10, all right? However, there will be Coding Clinic references made in your textbook, so read them, use them, refer to them, all right? Okay? The Coding Clinic is going to provide really up-to-the-minute information for you. If you get confused on how to code something or you're not sure how to code something, chances are somebody else in the coding industry has had the same question. So the Coding Clinic is someplace that we can contact and say, hey, we need some guidance here, okay? All right? So you're going to look in your Coding Clinic for clarification. That's where you're going to code. That's how you tackle that. You start reviewing your record, follow those steps through. If you go through and follow these, you will absolutely not have a problem. All right? So, review the record, identify the diagnoses and procedures to be coded, identify the principal diagnosis and principal procedure, identify your main terms in your alphabetic index, review any subterms under the main term in the alphabetic index, follow your cross-reference instructions such as see also and see, verify the codes selected from the alphabetic index in the tabular list, refer to any instructional notation in the tabular list, includes notes, excludes notes, your conventions, right? Assign your codes to the highest level of specificity. Code the diagnosis and procedures until all the elements are completely identified and sequenced in accordance with any applicable guidelines or conventions, right? That's gonna get you there. All right? So, any questions? Let me know.